I think the very fact is that education ought to be able to prepare a person for a variety of different things. It should open your minds. And of course, it provides information and knowledge that is relevant to what you're studying. But I think much more than that, I feel what the King Edward Medical College education and then training and exposure in the US helped to do was to broaden horizons, to look at things differently, to take in different points of view and try and to get them involved in your own decision making and to be informed by others, to inform others, to learn and to constantly challenge and re-challenge your own held beliefs, ideas. And every new knowledge, of course, is then supplanted by yet another new set of ideas and findings. So I think this concept of constant change, of learning from others, of remaining open, this was one of the most important aspects of this education that I was very, very lucky to get from King Edward Medical College, even before that, and then, of course, onwards to the US and then subsequent work at Shaukat Khan. So I went in 1989 and I started my residency in internal medicine at the University of Connecticut program. And I was there for 3 years, from 1989 through 1992. That was my internal medicine residency. And from there on, I went to St. Louis, Missouri, where I was a fellow in infectious diseases, which is a subspecialty of internal medicine. And the institution was the Washington University School of Medicine. And that was another great experience of learning from some of the very best people in the field. So I think that I want variety of challenges. So in many medical specialties, the knowledge areas are specifically directed to one organ system, which is great. People become very expert in their knowledge areas and their skill areas. So they really become super experts in one specific area. The interesting bit about infectious diseases is that the range of conditions and situations that it presents you with really go across the entire body, and it has, you can have infections of one part of the body or the other part of the body or something that affects the entire system. And then it has these inroads and connections with things like epidemiology and public health and disease spreads and statistics and research. So I think it's very, very diverse. And this diversity is something that really attracted me. The most important thing for me was this constant challenge of trying to fix problems, fix unknowns, find and solve mysteries. So I think within the infectious diseases community, this was a well-known fear and a well-known apprehension that sooner or later we would be faced with a pandemic. And there were little demonstrations of that as well in recent decades, SARS and MERS coronavirus. And so there were these things which really never became pandemics. Nevertheless, in the limited infectious diseases community, public health community, amongst microbiologists, virologists, there was this fear that this was bound to happen at some point or the other. But your question is very valid. Why was the rest of the world not too pushed or not too aware or not too prepared with it? One was that the last time a real pandemic of this sort had occurred was, 100 years ago. The second was this idea that the battle against infectious diseases had been won. Although within the scientific community, this was clear that this was not so. Antibiotic resistance had become very common, and we were faced with new bacteria, new viruses, new organisms every single year. But the fact is that the idea of infectious diseases being treatable or conquerable or manageable had gained a foothold in the 60s and 70s and 80s with the advent of antibiotics, vaccination, elimination of smallpox. So I think the general idea was that, look, we can sort this out. But amongst those people who knew better, there was this greater understanding, which was that this is a hugely interconnected world. the kind of intermixing that humans have today is just unparalleled. And even when you compare flight traffic patterns and movements just from a decade ago, the differences are stark compared to then. And then the sheer density of the population, and the very fact that dense populations intermixing, and this whole idea of pathogens jumping from one organism to the other provided this real almost perfect storm for having something come up which was potentially lethal and spreadable. And there you had thousands of flights and people, millions of people moving across, and suddenly you had a global epidemic which is called a pandemic. I think this is full 2020 hindsight advice, so it should be taken with that prism and that context in mind. I think there was an opportunity to be able to restrict or limit or reduce the spread of disease by earlier interventions, by better tracking of people who were getting infected. So better testing, better tracking, and more targeted approaches to limiting spread. Because possibly there was a time when it could have been limited in its spread. But I think that window of opportunity was relatively small. Because within a few weeks, I think people had traveled all across the globe, and therefore from there on, the issue was to try to contain the disease rather than to completely suppress or eliminate it globally, at least. So I think that's one thing. But this is all in hindsight, and I think the preparations from here on, I think the countries, governments, health systems have definitely learned. And I do feel that we will be better prepared. I think the entire world will be better prepared for the future because everybody had to build systems, response systems, detection systems, collaborations, cooperations, and novel and new solutions to problems that people had not known. So I think what has been learned will not be unlearned, and this learning will seep into the larger systems, into the response systems. Here in Pakistan, we hope to actually learn greatly from it and actually build a proper CDC for Pakistan. Thank you. I think this will go down as one of the cases of how crises get managed, and all the do's and don'ts will also come out of this. What happened is that back in late December, January, when it became clear that there was a serious potential of a viral infection, later known to be coronavirus infection, which causes COVID-19 disease, had the potential of coming to Pakistan and to other countries. The Ministry of Health, under the leadership of Dr. Zafar Mirza, formed a working group, a committee to respond to it. And he invited me to be one of the expert members, and there were other key members in that setup. He had epidemiologists from his own ministry. He had the National Institute of Health involved in it. He had involved the aviation ministry in it. They were collaborating with the military in that. And so there were a number of different partners to put together a response. I had actually invited and recommended that Dr. Faisal Mahmood from Aga Khan be invited as one other expert. It should never be just one person who offers expertise. You should always have a balance of view. So all of us started to work, and we would meet virtually every single morning. But I think by mid-March, it became clear that the epidemic and its impact had gone well beyond health. It required the full efforts of the entire state. And so therefore a decision was made at the governmental level to form the NCC, and then that gave birth to the National Corona Command Center, and that NCOC really became the operational nerve center for the response. It was it's chaired by a federal minister, Mr. Asad Umar, and he's assisted in this job by a military component who help in the logistics, the coordination, the follow-up, and a lot of the administrative side of things. And then on the professional side, there were, of course, the health ministry with the expertise available within it, I, of course, served in it as the PM's focal person for COVID. But beyond that, the real important part of this NCOC was not just the people sitting in the room there, but people who were called into the room for their expertise and involvement. Ministers for industries, ministers for commerce, the interior ministry. Every week there were multiple meetings in which the provincial chief ministers and the chief secretaries and the health ministers and the health secretaries were involved. So the real important thing that happened was creation of a system where a coordinated, coherent response could be built, synthesized, evolved, and completely in the line of data. We had people helping us in the data part of it. We had data modelers, we had epidemiologists to look at that portion. We had people from Digital Pakistan, we had the National IT Board, to help us on the digital backbone and the solution finding of this whole response. And it was very dynamic. As problems arose, and well before they arose, some of them were preempted, were thought of, planned for, solved, and any stakeholders that were required were brought into the mix to help. Whether it was the telcos for contact tracing, for data, whether it was, for example, the oxygen suppliers in this country when it came to a situation where we thought, well, we may have a shortage of the actual oxygen supply, to reaching out to the hospitals, the hospital administrators, to find out where exactly the ventilated beds were, how many staff were there, how much PPEs were required. And then, of course, a massive effort was done by the NDMA to make sure that whatever was required was brought in at short notice and in the most efficient way. So, I think that this will go down. As you said, there was no playbook. And the playbook was written as the play was going on. And it was adjusted and modified and refined as time went on. I would run out of time if I listed the number of entities and people who have stepped in to help to inform this decision-making process, and then not just inform it, but to help implement it. All the way from the contact tracing teams, the rapid response teams, from Islamabad down to all the provinces, all the way to GB, then the provincial administrations who had such a hard time in making sure that the lockdowns or the smart lockdowns were in place. I think this will go down as quite a special effort in Pakistan's history. The first and foremost thing to remember is that the vision and the primary ask set by the leadership, by the Prime Minister, was that, look, find me, he said very clearly, find me the path which will help us save our people from the disease, from its devastating effects, from the deaths it will cause, but yet allowing for life to continue so that people have a livelihood. Now, this was a hard one. To be perfectly honest, at one stage, a good part of the society, a good segment of the society felt that the only choice was a blunt, broad brushstroke shutdown of society. Now, as a very temporary measure, that was probably required, but and as we've seen, I think a lot of data is coming out now, which shows that it's a very blunt instrument, and some of us sort of realize this. So the primary ask was to find and calibrate your response in such a way that you were able to slow the spread of the disease, such that your systems did not get overwhelmed, and yet you allowed some modicum of continuation of life or of continuation of economic activity, so that people could would not starve and would not go out of jobs, and also to mitigate the other impacts like health, the impact on non-COVID diseases, immunization, tuberculosis. All these things were set to suffer in a full lockdown. So that was the fundamental ask. Now everything got synthesized from there on. We looked at data. The most important point was finding information, data. Where were the tests? We started with 4 labs. In fact, we started with 1 lab. It grew to 4 when the NCC was started. And then from there to over 100 laboratories across the country. So the geographic domain, across public sector hospitals and laboratories, private sector laboratories, non-governmental entities, small and large, and to actually connect them all to a single dashboard and database where all the lab tests are coming in. This in, I would say, in peacetime, in non-epidemic time would be something, but during an epidemic, to build this during an epidemic was something that I think there are plenty of unsung heroes who made this happen. This was, by the way, just added on to what is the polio dashboard, and people felt, well, that maybe is the best one to go by. You're of course familiar with the polio effort yourself very much. And so this was piggybacked onto it. But it had to be built, and it had to be such that it did not disrupt work at the coalface where the lab tests were being generated. So everything had to be connected automatically. So that was the first building block that was done. And then, of course, thereafter, not only that you had connectivity, but at the same time, you were increasing the number of labs. You went from 4 to 8 to 10 to over 100. And so each new one had to be added in. The other data point that was very, very crucial for us was where were our health capabilities? How many ventilators were available? How many ICU specialists were available? Nurses? Did they have PPEs? So the first thing was to map where all this was. And you might be surprised, over 3,000 Pakistani institutions report their dashboard 4 times a day. And you know what the compliance is? It's 100%. It's almost an unbelievable number. But the fact is that this was built with the cooperation of the hospitals, with the hospital administrators, the health departments, the provincial health ministries, our IT people, with the National IT Board, and with the help of the military in doing follow-up and making sure that we were all on the same page. So it brought comfort and confidence into our data on people on ventilators, PPE provision for healthcare workers, those who were dying unfortunately, what our capabilities and capacities were. The next thing to build was to find out, to provide this information to the public, because as you start to fill up your health system, it started to happen in June, as you know, it was very important to know where the available capacity was. There may be a ventilator available a kilometer away, but I might not know it. I would only go to my preferred hospital, and if that's full, I might say, well, what to do? So this visibility of availability was a very crucial bit. So this resource management dashboard was built. Again, it had the effort of all these other players. And so suddenly you had visibility, and even for the public, we have this app that can tell where the ventilators are in a particular city. It will tell you by your geolocation. So then there was this huge challenge of communication. I think to communicate the risks to the public, to mold and change their behavior and opinion based on the thing. There was almost a divide. There was one Pakistan which was screaming for lockdowns, and there was the other Pakistan which was almost nihilistic about it. And you had to address the entire spectrum of the Pakistani population. So this constant, coherent communication was again something that was made possible by our experts in the room in the NCOC, whether it was the Ministry of Information or whether it was ISPR and their joint collaboration, and of course our social media partners. I think that was very crucial to be able to get everybody on board. I think the other big thing that had to be built in, talking of playbooks, was the ability to reach out to the provinces. We are a federated structure with almost complete devolution of healthcare to provinces. And then suddenly to expect this cohesion was a tall order, but it happened. And I think we built a lot of trust with experts in all the provinces, with the health decision makers and the political decision makers, all the chief ministers. I think every single decision I can tell you that was taken at the NCC and the NCOC was a collaborative, consultative, data-driven, data-backed decision. So you're absolutely right. This has been a grand equalizer, I think, across vertical and horizontal domains. Really, nobody and no one was safe from it, and from the most privileged to the most underprivileged, everybody faced nearly the same challenge. So about regional systems, I do think that not all outbreaks become pandemics or global epidemics, and so some do remain limited to regions or countries or a group of countries. So I think it is important for the SAARC region to also have some cooperation in terms of not just detection of disease, but also learning from best practices from each other. Because I think, given our challenges, we have large populations, and our resources are relative to the West are much less, and therefore to utilize innovative and smart deployment of whatever is capable into fighting this would be important. I think this cooperation is something important to think about. Tremendously, because at the end of the day, you had to have people who were coming with certain symptom complexes. Look at the patient does not know whether they have polio. They come to know through a set of symptoms. So, you have what is called acute flaccid paralysis. So it's a syndromic definition that is used out in the field to flag a possible suspect for polio, and they're tested. Similarly, for COVID, we had a set of symptoms that were important to direct our focus. Somebody who had cough or fever, or were in contact with someone who had a similar illness. So therefore, you used a symptom complex. You used syndrome to identify. So exactly the same methodology was used. And then, of course, just like in the polio system, then you test. Here again, those with likely symptoms were then routed to getting tested. I really think that the existence of the polio system and how it stepped up to the plate. There are plenty of heroes in it. There's Dr. Rana Safdar and his team, I think, who were just phenomenal in making sure, and they're quiet heroes. It just happens quietly. Suddenly you have this dashboard today that looks so comprehensive, but it's been literally cobbled together. So I think the polio program's existence, both of its people and its knowledge and of its technology, all of it helped. At various junctures, you had to speak to, as you're correctly pointing out, you had to speak to a very diverse audience and people with their own experiential opinions about the disease. And then at various stages that changed as well. So you had to talk a language that was understood by everyone, but then you had to talk a strategy that was eventually good for everyone, which was a collectively good strategy. And at many junctures, it was not clearly obvious to one part of the audience or the other why the collective strategy was actually good. There were people who thought that the slowdowns, lockdowns, restrictions were not harsh enough. And then there were others who thought the opposite. And so finding this middle path and then using our celebrities and our spokespeople to reach out and explain this was very, very useful. We used a lot of important messaging through key and very highly respected anchors. They were invited at multiple times into the NCOC. We shared information with them and had very open and frank discussions, and were willing to share even our missteps. So I think this communication helped mold public opinion and helped in creating a better response. But I must say that we still are in need of it, because at the present time, a lot of people have just given up wearing of masks or using any precautions. And I do feel that we are risking ourselves and risking our success by doing that. And I wish and hope that we can still mold public opinion to at least continue to exercise some caution, especially as our schools and educational institutions open. That to me is one of the most pivotal openings in this entire story. So I think you're absolutely right that there was a time when the morale within the healthcare system amongst doctors and in the society at large was low, and people were afraid and scared and jittery of what was going to come to happen. I think one of the most important things to remember is that, first of all, there is in every epidemic which is new, which is of an unknown or a new organism, that everything is not known. Time will tell of this complex interaction between the pathogen, which is the virus, the host, which is, of course, the human beings, the environment, and then, of course, the social and socio-economic structures of a society. So beyond those unknowns, I can tell you the things that did help us was better mask wearing, the very effective contact tracing that we were doing, The smart lockdowns also played their part. As you said, better communication and reaching out, and the overall coherence of response based on data. So I'll give you an example. Our approach was always based on what made scientific sense. And even the science kept changing, as you know. The masks were initially sort of a kind of a conditional or a partial recommendation, and eventually it became a more definitive recommendation. But despite the fact, we went by the science of the time as well as what made scientific sense. And based on that, the recommendations always evolved. So we felt that it was very important to be able to contact trace and reduce the spread of disease that way. Now, that evolved eventually into the more targeted or smart lockdowns. And the idea was, instead of locking up the whole city, can we actually have zones or areas that could be locked up? The other important thing that got deployed was, we felt that if we were looking for perfection, if we thought, well, if it's going to be a lockdown, it has to be a China style complete. Well, we realized that our societal structure is different, and that even partial implementation of some interventions actually manages to take out the multiplicity of spread, and so that also helps in lowering the curve. Other factors may have helped that we are, as I said, unaware of that, and those will get known with time. So, in the first Eid, just before that, a series of openings had occurred. And I feel that because there had been a set of restrictions, the lockdown before that, there was a reactive sort of increase in movement, and that did contribute to the uptick, to the increase in cases in June that you were describing. Now, as you know, if there is increase in movement today, it takes a few days for that increase to actually generate the new cases, 5 to 7 days. And then, of course, it takes a little further time before people actually get unwell enough to reach the hospital and for the health system to start picking up the signs of the fill-up. So it was very clear. You could actually mark the days from the 11th of May onwards when this increase happened. And of course, we saw a pinnacle in June, or the second or third week of June. And what brought it down was also our actions. I do really think that actions contribute to how this epidemic behaves. After all, it is a respiratory illness that is dependent on relatively close personal contact, especially in closed spaces. So any time that you open an activity that happens in closed spaces where there are a lot of people is bound to impact this. And all the precautions that one takes around those activities then helps too. We had a number of events after that. So we had the second Eid, and then we did not see that kind of increase. And I think it was testament to the public, the communication that was sent to them, as well as to the provincial administrations and local administrations that helped to contain the spread during this time. The animal, the mandis, etc., were there, but I think they may not be perfect, but they were handled better than, for example, what we have seen in previous years. There was some respect of distance, and of course, you will always find somebody who will say, "Well, there was a lot of crowding." Of course, but as I said, never can we hope to achieve perfection in such a complicated situation. And so, what you achieve is some impact, and some impact then translates into slowing the curve down a little bit further, and then a little bit further. So I think it's been incremental steps that have helped us. But of course, as I mentioned, some unknowns still lurk out there, and we need to be able to do more research to find out exactly what differentiated our situation from our neighbors on either side and the rest of the world. So look, I think people misunderstood this idea of herd immunity right in the beginning, because a certain figure of 68 to 70% was put up, and people thought, oh, you have to reach that before it works. So it's not a binary. Immunity, or the acquisition of immunity, is an incremental process. So with every one extra person in the community, in the herd, that is immune, reduces the chances of spread by a little bit. And so as you have more people that have had disease, either symptomatic or without symptoms, but that have cleared their virus, do become immune to it for most part. And so once they become immune, they do contribute to the reduction or the slowing in spread. So the study that you mentioned was done across the country in a very systematic way. So the average is 11%. But it's got variations. It's got lower numbers, single digit numbers, but also places with high teens or 20%. So you're right. It is also quite likely that some of the existing social networks did get saturated, had their infections, and so one of the factors for the reduction in spread could be, as I mentioned, 4 things: the famous triad of pathogen, host, and disease, but also how the host actually interacts with other hosts, the social setup. So in less densely connected networks or in less mobile networks, that saturation may happen at a different pace than compared to a very, very dense and busy and heavily interconnected place like New York City, where you live. So the testing of immunity is done by these serologic tests that can measure immunity, and there are various levels and tiers of how accurately or how much in detail you can actually arrive. So the stronger the titers, the stronger the antibody response, the more likely, and you must have seen in that study as well, the more likely the benefit was from that. And the benefit generally is at an earlier stage in the disease. So yes, there are labs who can do that. And there are some further refinements of the antibody testing that are coming and probably are around the corner that can actually differentiate between the early immunity, which is the IgM, and then the later immunity, which is the IgG. And so some of those are also in process. I do think that our laboratory system and our health system has also gained, I think, in capability during this time because of there was a need and demand and to rise to the occasion, and I think that has happened too. So look, there are at least 120, 130, maybe more candidate vaccines all over the world. And about half a dozen of those are those that are the more likely winners in this. And they approach the problem from different sides. The nature of the vaccine is different. The scientific methodology that one has employed versus the other is different. So there are about 5 or 6 of these, or maybe more. And Pakistan is currently, we actually have a vaccine committee to look at this. So we have an experts committee that actually looks at the hardcore medical side of it. Okay, where's the science for it, and what's the most likely candidate that will help. And then there is a larger organization that looks at it strategically as to where to go. And the present plan is to narrow down into perhaps 2 or maybe 3 candidate vaccines on which to place our expectations and hopes and investment on. And we hope that will happen, and then those would be available to us. But crucial with this vaccine strategy, and again, you will know from your polio work that it's not enough to have something, but to be able to deliver it and to the right people. So this prioritization of who would get it first, who are your most useful initial candidates, your frontline workers, your vulnerable people, and then moving on to the larger population. So I think that's another important thing and another piece to solve and to implement, because again, from polio work, we know clearly you may have a product, but doesn't mean that it gets everywhere. Yeah, we've been very open about it. We've held webinars, seminars, communication to really address this question. And people have reached out to us from literally all across and asked, okay, what do you think has worked? And after there's obviously sometimes an initial skepticism. Oh, it's too good to be true. But the fact is that the data is all consistent, whether it's the systematic data, the anecdotal data, the secondary checks. So once you get past that skepticism, you say, okay, fine, we agree with what's happening, but tell us how or why it has happened. And then, of course, you struggle with what importance to assign to which effect. So we've been very open with the world as to what we are doing and what we think, or which are the factors we think actually have helped us in being where we are. And yet, underlining and stressing the fact that it's not over yet. As I keep saying, the schools are around the corner, and I think you put 50 million kids in educational institutions, in relatively tight environments. So you will need special means and methods to ensure that that does not become another engine for the spread of the virus. So there's been extensive consultations with the education side and the education ministries in the provinces, as well as with the leadership in the provinces, as well as with those that are actually imparting the education departments, as well as the private educators, all the way from very large, high-end school systems to the small school systems that exist in local neighborhoods and the mohallas. So we've tried to engage everybody, and I think by early next week, by maybe end of the day, Monday or Tuesday, you will have a fairly concrete set of guidelines as to what we recommend ought to be done. And we've focused on doability and impact. Yes, I can tell you a bit about what I know and then conjecture about what I don't know that well. I think it's also provided, while it has provided all this pressure and pain and deaths, but it's also provided opportunity for health systems to become front and center in the agenda of political decision makers. I think that's a very important one. The second thing that it has done is also highlight our vulnerability, not just for health systems, but for other things. I mean, we are so interdependent on each other in this world that you take out one element out of the mix, and suddenly you realize it has implications and impacts in domains that you cannot even think of. So I think the need for better communication, better investment in sustainable and local solutions, and the impact on how we can change the way we do work, our movements, the number of Zoom meetings the world has done in this time must have set some crazy records. So I think it will eventually re-engineer a lot of the life around us, how it has done, what it has done to the hospitality industry, to the restaurants, to the airlines, and to our mindsets. So I think that only a year later, I would say, this time next year might be a time to look back and say, what had this disease done to us, and how we have changed in response. So a lot of bits and pieces of this are either in the works or have been done already. But I think it'd be very important to study this systematically as a case in crisis management, and a case as a case in government, because I think some of what was done was at least unprecedented for us, and I think for large federal countries, it holds very important lessons. If you're a small, uniform kind of country with, stable systems, that's one thing. But for the Brazils of this world, United States, India, Pakistan, large, complex federal structures, there will be lessons in this that ought not to be lost. And I accept and I understand that what you're saying, but I don't think that at least a comprehensive study of it is in place. We have the components, but nothing that could really lay out the entire story and analyze very scientifically what did and what didn't work. But as I said, this will take a little time. You need some 20/20 hindsight to be able to do that in an intelligent and credible way. Two to 3 years is a bit far to look at. But what I would say is that, at least for Pakistan and globally, winter would be important to look at, because respiratory illnesses and infections do normally rise during colder months. So this coming winter for the whole globe, for the Northern Hemisphere especially, would be an important hurdle to go through. Beyond that, I think the availability of a vaccine might become more realistic. And so that will also impact on how people respond to this. And then the larger impact beyond COVID and beyond the vaccine would be this whole idea of how we view global health, this concept of One Health, and how we are able to really do things that are more useful and perhaps spend lesser time on lesser useful things. Really a prioritization of what is important in life. I think, as you said right in the beginning, that this was a grand equalizer. I completely agree. I think it put everybody, it put the Mahmood and Ayaz in the same line. Generally, viruses and viral infections tend to become less virulent with time, simply because the less virulent a strain is, the more likely it is to spread with relatively less symptoms, and so very often less virulent strains become more predominant. That's not a given, because you can actually have sometimes mutations that are deadlier and yet have the ability to spread. So while you can't sort of hang your hat on it, but generally viruses do, over a longer course of period, become the less virulent strains have a chance of becoming the predominant strains. Again, you can't call this out specifically for a specific virus because you really don't know, but that's a sort of a generic statement. What COVID itself will do, I don't know, but I do believe that from all the evidence available, we're likely to have it for the next many months. Beyond that, I think it's a bit hard to say. But then, we need to look beyond COVID as well. We need to look at the very fact that our present population, the global population, and how it is interconnected and how many of its dense centers act and work, it should be something that we need to address. I really do think that the use, in the impact on the environment in general, how animals are treated, traded, eaten, that whole area is something, veterinary use of substances, antimicrobials, human use of substances and antimicrobials, the impact on environment in general, what warming might be doing to us. These are obviously crazily complex situations, and no one person will have the answer to this. But at least this disease ought to have brought focus to the global leadership on how crucially important health is. It has the opportunity of disrupting every progress you've made. You've seen what has happened to economies in the entire world. So, you may not have COVID around 2 years from now, but you will certainly have to think of the next epidemic and how it impacts in life in general. So I think they were, without a doubt, they've been impacted heavily. We've lost so many health workers who were frontline and gave their lives, and knowingly, in the sense that they knew that they were putting themselves up for risk. And there are many heroes who continue to work through this, and they took precautions. And yet, there is always a small risk of catching the infection, and then there is a further risk of being unwell from it. But beyond the immediate death and disability, the effect that it has had on the morale and thinking of many of our healthcare professionals is also worth considering. It has scared a lot of people as well. People shut down clinics, and people rethought their whole professional specialties to even work in. But I think that what the government did was 2 or 3 important things. One was a reach out to them in terms of moral support. That's important. But one of the most important symbolic and practical means was the ability to get personal protective equipment. You will recall there was a time, there was a global shortage within Pakistan or one thing or the other. But eventually, and in very short order, because of the help from the NDMA and our local industry, whether it was masks, gowns, other protective equipment, it got delivered accurately. And so there was a brief time and there was a lot of fear about this. It went away not because people became fearless, it went away because people were provided with personal protective equipment. The other bit was recognition. I think we did recognize on the 14th of August people who had laid down their lives or who had done extraordinary work on the front line. And you can't recognize everybody, it's almost impossible. But at least that symbol was there, and it showed that the society at large, the government, and the public at large really did feel that their healthcare workers stepped up to the plate and were there to help them when required. I think all societies, but ours in particular, places a lot of respect to the healthcare profession. I often tell my young colleagues that you may be 25 years old, and suddenly this 80-year-old man calls you Dr. Sahab. And this Sahab business is because you are supposed to be part of a profession which helps others, and there's a certain nobility associated with it. Why otherwise would somebody old enough to be your grandfather call you Dr. Sahib? So I think that many of our healthcare professionals actually earned that Dr. Sahab or Dr. Sahiba or Nurse Sahiba or other professionals during this whole thing. And I think this is also important for us to remember that when we have systems that select people to go into these professions beyond raw academic numbers, their commitment and their personalities are equally important as to who ought to go in there, because this epidemic has shown us that it's not just knowing your medicine or surgery or microbiology, it's your humanity that counts. So yes, I was displaced from my home, and I had great support from people I was working with. I made great friends, and I really found some immense people and individuals. So friendships and that network is there. But also, don't forget your own families. They do suffer. Mine has, I know, because I was have been away for months now. Although I make this effort to come home every weekend. But I think beyond these normal sort of platitudes, the other thing to do is to be able to take care of your own self. I think many of us lost our exercise or activity routines. What we eat and didn't eat also got disrupted in it. I think it's also important to first take care of your own self as well. I've tried, but I think I have to confess that at least for me personally, the normal routine was terribly disrupted because of the hours and displacement from home. I think there are plenty of private providers, partners, development partners who work in the public sector and the private sector who already partner with the government. I'll just, without naming specifically, let me mention a whole industry, the lab diagnostic network. Look, we as I said, started with a handful of labs, and we now have labs, a PCR lab in places where you never could imagine that you would have this sophisticated test available. And so this only happened because these entities were ready to partner, ready to learn, ready to adopt technology that was given to them, and then work long hours and then keep reporting. And till today they're doing this. So I think there's a whole number of them. I wouldn't single out any, or else it looks a bit unfair. But yeah, I think that this whole ecosystem also needs to be catered to. Healthcare delivery in this country is done primarily now by the public sector, by the private sector. 70% of healthcare delivery at the point of delivery is by the private sector. So certainly the government needs to partner with them, because instead of investing on brick and mortar, we need to be able to make sure that the entire health system works. For the poor person or the man who can't afford, I think these safety nets like universal health cover, we just heard KPK announce universal cover for everyone. I think that's great, and for everyone else to emulate. And these are not easy to implement, but these are great starts. It is so empowering for a poor man to be carrying a card or a number or something which says, if I'm unwell today, I will be taken care of. I think it's a great building block of a just and social society. I mean, a just and fair society. look all across the country, whether in public or private sector, there were hospitals and health providers who were ready to say, well, we are going to allocate beds, we are going to allocate facilities to make sure that if the need comes, we can provide this care. I think that was a great thing. I don't think we had to force anybody really, barring a few instances here and there. Generally, the healthcare system felt that it was now their moral and professional responsibility to be able to partner with the government for providing this care. I do feel that sometimes we don't give enough recognition or enough importance to that partnership. And thank you for asking this, because I think that highlights that little gap that has existed. So I would say the development of human resource in public health, in epidemiology, in data sciences, in behavioral sciences, in the management and communication expertise, in creating these networks of centers, or a center that is able to collate, analyze and interpret data for epidemics, the CDC that I keep talking about. I think these would be the things to invest in for the government as well as for any development partners who feel that here is a success story. Let's make it permanent. And I think the bottom line is that while we know bits and parts of it, we do need to study this more systematically. But I think for full clarity, sometimes we have to be a little distant from it. So I think it might be a little while before the full impact of each factor, how it contributed into this, would be done. I think people will get and write articles in scientific publications and gain PhDs and whatnot from this.
Thank you, Doctor.
Thanks. Acha.